Hello, I'm excited to be here with you to talk about strategies to reduce health disparities and improve outcomes in breast cancer. I'm Claudia Hardy. I'm an instructor in the Division of Hematology Oncology at the University of Alabama at Birmingham, and where I also serve as the Director for Community Health Access and Relations here in our Office of Community Outreach and Engagement at the O'Neill Comprehensive Cancer Center. But I'm excited here to share this platform today with my colleague, Dr. Erica Stringer-Reasor. Dr. Stringer-Reasor, welcome.
Hello, my name is Dr. Erica Stringer-Reasor. I'm an associate professor of medicine at the University of Alabama at Birmingham, as well as the breast cancer director at the O'Neill Comprehensive Cancer Center. And I too am excited today to bring more enlightenment and enrichment to healthcare disparities and talk about some of the risks and strategies to reduce these outcomes and improve outcomes for patients, all patients that we treat.
Awesome. So it looks like we got a jam-packed session here with our time here, but we're going to try to get through this as quickly as we possible. I think probably you're okay with me calling you Erica for this. And so why don't we jump right in and start talking about some of our breast cancer facts and really identifying some of the variables that contribute, if you will, to our incident and mortality based on race here for breast cancer.
So certainly, we're certainly seeing a trend, uptrend of the breast cancer incidence in 2023. There's a projected 297,000 patients to be diagnosed with breast cancer, and about 43,000 deaths are projected in 2023. So if you're looking back over 2021 and 2022, there's certainly an increase in incidence in breast cancer. There are some things about the COVID pandemic, and we're seeing that there's going to be a health disparity as far as access to care, and it was access to care to all patients, but specifically, some vulnerable populations that were already underserved even before the pandemic, we're seeing those health care mortalities increase. And so we're all very familiar with the mortality rate of Black women compared to white women being a whopping 42% increased mortality. And this is across all subtypes of breast cancer. We particularly talk about triple negative breast cancer, as this tends to overwhelmingly be diagnosed in Black women, but we still, from an epidemiologic background, know that more Black women are still more likely to be diagnosed with hormone receptor positive breast cancer. So if you look across age, stage, we will know that Black women just have higher mortality for all types of subtypes of breast cancer, and that includes triple negative breast cancer, hormone receptor predominant breast cancers, as well as HER2 positive breast cancers. So Claudia, you're out in the community and you're seeing some of these risk factors that patients are being diagnosed with breast cancer. Can you speak to some of those risk factors that specifically are you see in communities, in Black communities?
Absolutely. And it is an amazing thing that as we start talking about risk factors, we also are still thriving, if you will, and surviving during this COVID pandemic, in which has caused all of our communities, particularly these communities of color, to really be impacted the most and have more comorbid conditions related to these risk factors. So when we start to look at some of these breast cancer risk factors, we know just being a woman puts us at risk. And we know the older we get, the greater our risk increase. But also, what we're seeing, particularly in our communities, are these environmental factors. And so we're looking at, issues around, are we near factories? Are we in rural communities where there are pesticides and those kinds of things? But we also know that because obesity tends to be greater in African American communities, we also see more women of color having this breast tissue, which indeed is a risk factor. And then these things here that have always been personal to me, women who've had their menses or their menstruation began before the age 12, or those women who go through late menopause. And what we know is that that introduces a longer period of time in which estrogen production takes place in our woman's body. But as I mentioned to before, issues around our BMI, the obesity rate are very prevalent, and whereas about 85% of African American women tend to be obese. Those was some data that was a few years ago, and I dare say that those numbers are still current. And so, because we have these diets high in saturated fat and processed meats and these kinds of things, these tend to increase the risk for African American women. And so, we know that there are other risk factors as well. And so, I'm going to give it back to you so that you can talk more from a clinical spectrum about tumor biology and those things related to these risk factors that we have.
So, Claudia, just speaking from a clinical perspective, I tend to, talk to my patients about those things, those risk factors that, perhaps we may can modify and change over time, such as, the things that you eat. So those diets high in saturated fats, and also, the increased input of exercise, and trying to normalize some of those weight patterns. But there are certainly some things that you cannot change. And we see that black women and younger women tend to have very dense breast tissue. And when we talk about dense breast tissue, again, we tend to utilize the mammogram as the gold standard to detecting breast cancers. But simply, if you have denser breast tissue, those mammograms are 2D x-rays, right? And so if you utilize 2D x-rays, it may not be as easy to read through or see a small mass or detect a small mass if your breast tissue is very dense. And so as a clinician, we tend to regulate that dense breast tissue as category C, and category D as being very dense breast tissue and may not highlight or find small abnormalities in the breast. There are other things that we talk about, those risk factors, as far as, personal or family history. And, what I see in the community, and you can tell me what you see in outreach, is that minority patients, Black and Latino, tend not to talk about some of the family history or personal history. And, I don't know how you mitigate that in the community, but I would, be really interested in how you can enlighten the audience. And then, too, that environmental risk factors that you touched on so eloquently about the water we eat, the environment in which we are in. Are we close to living factories? Are we close to, areas where, there are farming areas and rural areas, and even the herbs and the fruits and the vegetables that are grown there, again, may be also affected by the microenvironment in which we grow those produce. So thinking about all of that as the patients come into to the clinic. So I briefly talked about, tumor biology as far as black women are concerned, and breast cancer. They're again more likely to be diagnosed with hormone receptor positive breast cancers than triple negative breast cancers. But the reason that was so important that we talk about these strategies, and we talk about these health disparities, is that triple negative breast cancer tends to have higher mortality rates, and so even for smaller tumors, the risk of recurrence can be up to 25 to 30% in these women, and that's even for stage 2 and stage 3 disease. We also have limited treatment options when it comes to triple negative breast cancer. Previously is mostly confined to chemotherapy, but most recently over the last year, there's been some new advances in these smart drugs called antibody drug conjugates, as well as immune therapy has been now added to the armamentarium of breast cancer treatment. So it's really helped to change the algorithm of how we treat patients. But, I think more importantly, when we talk about hormone receptor positive breast cancers, we talk about the ability to have targeted therapies, and these therapies that target specifically the estrogen receptor and the progesterone receptor. And we often treat these breast cancers with oral tablets, and called tamoxifen, like these selective estrogen receptor modulators, as well as aromatase inhibitors for those postmenopausal patients. But part of getting adequate care is able to have access to getting those treatments. Many of them now thankfully generic, so they tend to be a little bit lower cost. But for our patients that are on limited income or have certain insurances that only provide up to 5 medications a month, and then they also have other comorbidities in which they need to provide their insulin, their antihypertensive medication, and now we add on endocrine therapy. They may have some choices that they have to make. And so, one of the things that I found in my practice is finding out, what if there are any financial barriers, because it's key to being adherent to these medications. And this word compliant, Claudia, I want you to speak a little bit about that, as, patients in the African American community get dinged on this compliance issue, but it's not a compliance issue. It's really an adherence. Tell me about that.
Absolutely. It is definitely adherence, but it's also, as the segue you just gave about insurance and what the insurance will cover, how many. Most people don't know, but all of these are what we now know as social determinants of health. And this is just the environment in which people live, grow, and work. But our insurance dictates how we're treated, what kind of treatment options that men and women have. And so a woman's ability to, or a patient's ability to have, to be compliant includes a lot of factors, and it's not just, some of it is understanding the instructions of the medication, which sometimes may involve our literacy. Some of it is also understanding the insurance plan. Some of it is also, it's a myriad of reasons why a person or a patient can be compliant with the health care, and with their instructions and the things that they need to do in order to be able to get through this breast cancer treatment. And so as we look here with the different types of breast cancer that exist, and in particular when we're dealing with minority and African American women, it is more than just a physiological aspect of being diagnosed and what the tumor and the estrogen and what the biology says. It is also has to do with the economic stability, the neighborhood, as we talked about, some of the environmental factors, education. It is, and particularly when we talk here, language and literacy skills. But a lot of this, in order for a patient to be compliant, and as we are all aware of the social determinants of health and what makes up the totality of that patient, it is also comes down to that person's confidence in you and in us as clinicians. And it becomes down to the empowerment of the patient to understand whether or not, or to believe that he or she is an active participant in their healthcare outcome. And in marginalized communities and a lot of minorities, oftentimes they don't feel like they have a role. They coming to hear what the clinician, the expert has to say, and then that's what I'm going to do. So all of this makes up the social and the community context by which, as clinicians, we're treating individuals, but keeping in mind that we have individuals and patients who present coming from different environments where they live, work, grow, and work. All of these things impact their health outcomes, their health treatment, and even the access to care. And while I started at the end with the outcome, oftentimes we do have to, it is where we need to start, because if we want optimum outcome, we do have to work our way backwards to look at what is the totality of this person, and then really looking at a lot of the socioeconomic statuses of individuals and those kinds of things. And we know Data has always supported that low socioeconomic status accounts for worse outcomes when it comes to breast cancer. And for a number of reasons, is related to many individuals don't have a medical home, and oftentimes they're having to seek health care. And by the time they present for diagnosis, they're at a much later stage of diagnosis. But what we've seen over the years in doing much of our work in communities that are underserved. It's just that also an individual's value and belief system has a lot with how they view the medical system. We know trust is an issue in many communities because oftentimes we know historically we've been seen as guinea pigs. We've seen where there have been incidents of mistrust. We've seen incidents where individuals, and particularly people of color, have received brutal treatment. And so all of these things really have impacted how an individual may approach the healthcare system, and it also impact the compliance rate based on how they believe in the treatment that is being offered to them, and how much they believe in the person, the clinician who's doing the treatment. And so for many of individuals in these communities, not only do they lack in a primary care provider, getting access, we know in many rural communities, healthcare systems are closing daily, and we know that certainly is our case here in Alabama. These many healthcare systems are closed. And so if you don't have a primary care provider, you need to have a mammogram, you need to have this test. Half of the battle is learning how to access the healthcare system in which you're trying to, and all of these things add to that patient's compliance.
Yeah, so let's talk about that kind of ecosystem here,
Okay.
and it's that those barriers that we talk about so much in patients getting good access to care and getting good access to timely care. So we have these kind of patient, we have the provider, and then we have this kind of system level barrier that certainly may delay treatment for patients or inhibit access to therapy. So, on a bigger level, when we talk about systems and policies, and we look at areas that are underserved or rural, and certainly if you're in a underserved or rural area, it's being seen as very urban, and they look at how much the patient and the family income is. If you are black, you're more likely to be a part of that kind of that urban rural area with limited access to financial gains or have financial barriers. So those patients tend to have a twofold barrier when it comes to that. Also, if you look at some of the things as far as like insurance level barriers, if you have Medicaid, again, you are seen to have limited access or limited access to funds, but you also may be disabled, right? That may be able to get you Medicaid funding, and some high level institutions or private community institutions do not accept Medicaid. And so, what's disheartening for the patients is, it disables them. It does not enable them to be able to receive care from these comprehensive centers that may be able to afford them trials or even just the standard of care. So let's just kind of stop back and step back and look that patients that receive the standard of care also do better if they have it in a timely manner. There's been a large phase 3 retrospective study from the Carolina Breast Cancer Group that looked at data from like 2008 to 2013 over almost 3,000 patients who had diagnosis of stage 1 to 3 breast cancer. So these patients were curable. And if you were to look at patients that were black versus non-white versus white non-Hispanic patients, black women were still more likely to have delays in their treatment greater than 60 days, and that's looking at the time in which they received their biopsy there. Additionally, if you were young, so younger than the age of 50, which we know those patients tend to have more aggressive disease in breast cancer. Two, they also, those patients, if you are black and younger than the age of 50, you also were to have longer delays in treatment, and also patients were more deemed to have longer treatment durations, right? So that means that they probably had more aggressive disease at the time they were diagnosed. So, we always think about this pattern of, could we have detected this breast cancer earlier in patients? And if we detect it early, what do we do about it? And there have been some centers that have really went out into the community, into some of the rural areas, kind of enforcing some of the mobile mammography units, which have been fantastic for patients that have not received screening. But we all know that the way screening works, no matter if it's breast cancer, colon cancer or cervical cancer, the way screening works is that patients get this annually. So they get this yearly. So to get a screening mammogram once in every 6 years probably is not going to be as effective as getting screening mammography once annually. And so, yeah, and so, so if you're looking at those, breast cancer rates and looking at screening mammography, the mortality in breast cancer screening is probably about 10 to 13%. Preventive, and if you look at higher rates, a way to prevent breast cancer, it really comes into treating patients in a timely manner. And so I really want to reiterate that, treating patients in a timely manner really matters, really matters as far as cancer outcomes.
But the other thing I wanted to just jump in and share also, timely access, but also where you're treated. And so, as you alluded to just earlier about where the mammography takes place, and so making sure that you have in a center where not only the mammographies are offered in the latest with the latest technology, but it's also important that you're part of a system here that allows for true clinical care coordination and that the appropriate follow-up. And so this gives us a segue into about getting timely treatment care, but what are the other areas? And this is where we want to talk about clinical trials, because clinical trials plays a very important role and should be seen as part of our standard of care when it comes to breast cancer. So take it away.
So some of the things that I think about in my clinical practice is that patients can come in and get treatment from a multidisciplinary team. So they're able to see not only a medical oncologist to think about systemic therapy, but they also get the input from a radiation oncologist and a breast surgeon all at the same time. But I would say even before they come through the doors, they meet one of our breast cancer specialists called a nurse navigator. And that nurse navigator really bridges the access between the providers in the clinic, and also kind of discusses with patients, are there any financial or mental health barriers that come into play. And when we gather all that information, one of the things that we do once the patient comes into this multidisciplinary team to get their assessment is to think about, are patients eligible for clinical trials, and if patient needs some type of systemic therapy, what can we do to facilitate moving their process along, whether it's CT scans, additional tests like echocardiograms. Do we need to address the patient, some of the patients, health issues as far as their diabetes not being well controlled, or are they a tobacco user, which in some cases may delay the type or limit the type of surgery that the patient's eligible for at that time. So we really want to, find out more about the patients. And we found out that using nurse navigators to bridge that first visit really helped us hone in on what that patient needed at that time. So let's talk all about the clinical trials. And yeah, I think if you look at all comers, no matter the ethnicity, you would think that in cancer care there would be more trials, that patients would be more would enroll more into clinical trials. But on a national average, we see about 10 to 12% of patients diagnosed with breast cancer actually participating in clinical trials. And then if we think about furthermore about minority patients, specifically Black and Latino patients, 1 to 3% of those patients will actually enroll into clinical trials. And even more disheartening is, patients come into the clinic and they say, how likely is this therapy to work for me? We continue to have this underrepresentation on FDA approved trials. Available for patients. And we just don't have that data. So we hypothesize, right, that, most of the majority of the patients were female and, this is what worked for them. So we can potentially say that it's going to work for you and your disease, but I don't think that any investigator can say for sure without a doubt that that's the case. We also have this issue with male breast cancers affecting 1% of the population, but we know that it does happen. And, up until several years, many studies excluded men from being a part of the clinical trials, which, one would argue that, even though men make up 1% of the population diagnosed with breast cancer, they too should be eligible to participate in these trials. And so, we certainly want to, afford that everyone can do that. So some of the things I would say, Claudia, as we think about these clinical trials and enrolling into some of these clinical trials, they take certain eligibility criteria, and some of those with patients that patient populations that have more comorbidities, sometimes they're more ineligible. And one of the other things that we're noticing is genomic status, so DNA of the tumor, and then germline mutations, so DNA, these germline mutations that patients carry in the blood. But we find that Black women are just not getting genetic testing. Can you speak to that?
Absolutely. And part of the reason is that is they don't quite understand it. Secondly, with education, we've been told, and many of our individuals that we engage with in the community, once they're educated and all of their questions are answered, particularly around genetic testing and clinical trial participation and biospecimen collection, they're eager to do so. And so that's why it's so important for us to do successful community engagement, where we have bidirectional communication and bidirectional relationship, meaning that not only do I present or I share information with them, with a community member, the community members share where they are. And so we get to be able to have an excellent co-learning exchange. And so that therefore we're able to develop and address health issues that affect them the most. And I've always used the analogy that they're about baby steps. But with community engagement, it is necessary to improve the outcomes for underrepresented population because it builds trust. So the more we're able to be present with each other and trust and get to know each other, it gives an excellent way by which we're able to do this. And so we are deliberate with our conversations with individuals. So as we talk about genetic testing and do genomic education and even clinical trials education, we want individuals to know today that all of these are now current standards of care, not just the last resort, but it is standard care. Ask for it if it's not offered. We know that there are a lot of biases that may exist, but if it's something is not, what we try to do is educate the community member so that when the community member comes to the clinic, they are very active. That they're able to share, and they're always seeking and trying to find the common ground so that they can approach these opportunities the best way that they can. And so, as we do these kinds of things, it's real important for us as we're doing engagement to understand the values that individuals have. We all have values. If it's something as simple as brushing our teeth regularly or before we go to bed at night, to walking 5 days a week, that for many that is extremely part of their value system because that's their standard by which, as an individual, that they behave or that they group things and judge things. And so um, it's a powerful ingredient, particularly when it comes to health behavior and decision makings about decisions that are made about our health. And so I always challenge our clinicians and even our researchers. Make sure that you understand the value system that each individual that you engage with have, because that determines whether or not they will enroll. It determines whether or not they will accept a treatment option. Going back to the issue around compliance, and then people learn from a wide array of different things that causes them to build the values that they have. And these values help make up the culture or these customs or arts that individuals have, because all of these again are part of what guides these health behaviors. And so a lot of the work that my team and I do is that we partner with our clinicians like Dr. Erica Stringer-Reasor to make sure that we are all being as culturally sensitive as possible. And all the thing we mean when we talk about cultural sensitivity is that we try to understand and be self-aware of the patient and what they present to us. It also helps us to be open-minded, but I always encourage anyone that you're engaging with to ask what they should be called. Even did that today with my colleague here. We ask. And so understanding body languages and those kinds of things, and then in doing so, it helps us to be able to really improve the compliance of patients in their treatment option. But it also helps us to recognize these differences in perspective, because all of the cultures and that we live in, they begin with these beliefs, and then these beliefs help really determine the behaviors that individuals have, particularly about our health behavior. And so, as we are treating breast cancer patients who come from many different communities, it's real important how long they've been in one community, what they've been exposed to, understanding that as we bring them into an urban setting for clinical treatment, they have to allow time. To get into a parking deck, or perhaps they don't have parking decks in the small communities that they live in. And so just understanding, making sure you have clear directions. And then the age. One of my greatest lessons, and one of the things that I always try to share as a key takeaway, that as you all are practicing clinicians, researchers, and all of us who are engaging with individuals, we're all engaging with individuals at 4 generations at least. And so the age of the participant and the age of the patient makes a lot, it impacts the behavior greatly. But more importantly, from all of us, it impacts how we can communicate. We got to use multiple methods of doing these things today. A phone call still works for many folks. And then if you're dealing with a younger generation, they don't want a phone call. They want it electronically. They want it text. And so it is acceptance of a lot of our American and our Southern norms here, the technology. So all of these things are real critical in how a patient will be compliant. And it's also real and critical as we provide care for them. And as we put it all together here, patients and the clinicians, we have to work together. So I think as we work on wrapping this up and talking through this, we have a case here that we want to walk through. Doc, you want me to walk through it, or you want to take it back from here?
Mm. Let's see, I can walk through it. So
Okay.
I think that, Claudia, this is, just a prime example of, knowing your patient population.
Hmm.
And so, this is, a case of a 58-year-old female with stage 4 breast cancer that had metastasized to the lungs and her bones. And so, one of the things that I do when I get a patient that's diagnosed with metastatic disease is, really make sure that that they have a caretaker or a trusted family member to come to the visit with them. I think a second ear, set of ears are, certainly very helpful. As you know, when we patients come into the clinic and they hear cancer, they may not hear much else that first visit, and so there may need to be phone visits and discussions thereafter, especially in patients that have more vulnerable needs and are more likely to drop out of or not be able to follow up because they have other pressing issues like child care, and elder care is really important now as the aging population is growing older. So really trying to address those and the mental health issues. And some patients lack of income now after the pandemic. So many people were had to leave and take care of their families or were laid off, and there are certainly a lot more financial issues that we have to address now. So addressing that supportive care. So in this patient, she ended up having a biopsy of her a bone done, and in her breast, of course, and it was found to be invasive ductal carcinoma, 90% estrogen and progesterone receptor positive, HER2 negative. And for many years, she went under the first line therapy with a CDK4/6 inhibitor, abemaciclib, and aromatase inhibitor, letrozole. And she actually did well. She did about the average time that most people patients in this similar circumstance would undergo. But eventually, she had a restaging CT scan that showed a liver mass. The biopsy again now was still invasive ductal carcinoma, still strongly estrogen receptor positive and progesterone receptor positive, and HER2 negative. She then went on to have a blood test, which is similar to a liquid biopsy with Guardant 360 assay, which found to show a ESR1 mutation. And so in about 25% of patients who have undergone treatment with an aromatase inhibitor, their tumor will acquire this ESR1 mutation that will make them less sensitive to hormone blocking therapies with aromatase inhibitors like letrozole. So eventually, this patient went on and to move on to a now new FDA approved drug with a selective estrogen receptor downregulator, elacestrant, and is on that oral therapy. So, one of the things that, again, if you're dealing with any patient, you should talk to them about why we take the blood test to develop that trust. We should talk to them about the efficacy of the drug and potential side effects of the medication. And for that full transparency there, and then make sure that you have good follow-up with the patient so that they know that they can follow up with you and reach out to you, whether it's via the portal, electronic base, or via phone. So that was one of the cases that we kind of wanted to put it all together today in these strategies of creating or bridging or decreasing the amount of healthcare disparities. So Claudia, can you give me one of your key takeaways from this strategic discussion?
Absolutely. And just this week I received a text message from a good friend of mine, colleague, because in addition to having that caregiver there, the caregiver and then care partner, as we say in our healthcare system, I provided them with a little journal book, and that journal book is as I always instruct patients and care members. It is like your little go-to. It is for you to make your notes when you're at the clinic. It's for you to jot down questions at home when symptoms arrive. And then that way you can be able to track everything in one place and you can just stick it down in your purse. But I think for all of us who are here as providers, that awareness of the patient's socio determinant of health, all of those things that make up that patient, where that patient live, work, play, in that environment, the socioeconomic level, the values and beliefs, all of these things are critical to improving the outcomes. And so it is more than what the biology presents, but it is combining the biology and being very aware of what this patient brings to the table. And I dare say one of my other key points I always share with providers is peel back the onions and peel back the layers. So while what you see presently, the more encounters that you have with that individual, the greater you're able to pull back the layers to see and learn a little bit more. And as you learn more, the trust is gained more. And then you and that patient can be able to really make strides in how we be successful in improving health outcomes. So I know we've talked about a lot of things over our time together today, and this has been a great and rich conversation. But it is one in which is constantly evolving. And I dare say, as we continue to live in this pandemic that has now been around for several years now, 3 years, how people present the things that the issues that make up the environment and the things that the patient is involved with definitely has been compounded, and it definitely impacts that patient's compliance. But I think it is critical for us as the providers and part of the engagement team to really make sure that each patient is in an equitable position to get the best outcome possible. So I'm delighted that I've had this time with you today, and we hope to be able to share more with you at a later time.
Absolutely. Thank you.